Hi, everyone, and welcome. We're waiting for as many people to come on board. I think we have a few more to join us. We'll give it 1 or 2 minutes more. My name is Shabir Musa. Okay, welcome, everyone. My name is Shabir Musa. This is an orientation of the interns for the stint of family medicine, primary health care. I'm a professor in family medicine. We have other colleagues on the call. I just want to quickly see Dr. Maggie Petkova has joined us. Hopefully others do join us in the next few minutes. I think there are a few more interns that still are joining us. I'm assuming that all the attendees know how to use this, so you can raise your hand if you have a question. I see there's a chat function that some of you have started joining. Maria is with Catherine Gear and Sarah Lee Curtis. Welcome and thank you. And I think, Sarah, is it you that has raised your hand, or Maria? So Maria, you've got your hand up. If you need to talk, that's fine. If not, you can put it down, but we can give you a chance later to raise issues. So welcome. The agenda for today is actually a bit long. We may have to change the format of the meeting. So I'm going to just quickly go through this. We might have to do COPC tomorrow, but I think most of the rest we will do today. Just a welcome and introductions. I've made that. I think if there are any other family physicians that join, hopefully I can introduce them a little later. I'm sorry. The next on the agenda is going to be just going through what Johannesburg is. It's quite surprising that people in hospitals in Johannesburg don't know where the begin and end of Johannesburg as a district is, which is unfortunate. They tend to think of Joburg as just the suburbs. Family medicine internship, what it's all about. There is going to be a document which will circulate. I'll just highlight some of the key do's and don'ts that you need to be aware of. We'll go through the teaching program and the process that's involved in and how we support your learning, because as an intern, you're an apprentice, and we have the HPCSA guidelines, which want to ensure that you have an experience that encompasses all of the expectations in that logbook. And yeah, so one of the things that we do need to deal with, and we will try to do that briefly, is the principles of consultation, principles of family medicine, and the consultation approach. We might do it better, longer, later, but I'll try to go through it very briefly. If there's some challenges, I might actually leave that for another day. But the QRP and referrals are actually important, so we may shift that up. And then I'll go through the COPC, and we'll close with any comments from any of the other panelists. One other person that has joined us, welcome, Dr. Moti. And I think we hope to get many more other family physicians and senior medical officers to join us. So we have about 77 people. We do have a register. We will have to just make sure that everyone's attended this. If they have not attended this, we will be taping. We are taping all these sessions, including the teaching program, and they will be made available to enhance the teaching overall. So if there are no questions or comments, let me proceed. Johannesburg is in fact a very big area. It's rather long. What people know as the town and suburbs are region F, which is where the city town is. Region B is the other part of town that many people know. And then often people don't realize that Roodepoort is part of Johannesburg, that Diepsloot and Midrand and Ivory Park are part of Johannesburg in region A on the north, and that Orange Farm, even though it is semi-urban, is actually part of Johannesburg. So these are just extents of Johannesburg. On the east, actually, people don't even realize that the OR Tambo Airport is not in Johannesburg. Bruma Lake is the extent of Johannesburg in that direction. So this is just giving you a sense of where Johannesburg is. And we have the three big hospitals. And I'm not sure that you see my marker, but essentially you can, let me just quickly point out, you basically have in region F is where at the moment you have Charlotte Maxeke. In region B, but really not very far away, is Helen Joseph Rahima Musa. And then in region D, close to the edge or closest to town, is the Chris Hani Barra Hospital. So these hospitals are all fairly close to each other when you compare the extent of Johannesburg, which is all the way from Diepsloot, Midrand to Orange Farm. Okay, going to the next, people don't realize that it is no small institution. There are in fact 5.5 million people, that's the population of Johannesburg. It is the largest district in the country. So this health district is an institution and it provides care to 10 million visits into primary health care, which is, again, no small number. It far surpasses even the number of visits at Barra. So when people feel all the world visits Barra, they don't really know what they're talking about. See what happens in the whole of Johannesburg. There are only 80 visits, 80 doctors actually in the whole of Johannesburg. So the 120 interns that are joining the district are an enormous value to the district, and you are going to be making a very big difference to the care that exists out there. Unfortunately, it is not 120 spread out, and we've deliberately done that because of various reasons. One is that that we find that supervision in small clinics is very difficult. So you will be mostly at CHCs, of which there are only 10, and other large clinics with doctors present. And then the other demands that have come along is for you to do internal medicine, and then the requirement of the HPCSA that you spend a month in a district hospital. So effectively, the interns on the ground are half of that number, effectively. We do have a number of nurses, and I think that as you go along, you'll see some of the challenges with nurses, but some of the benefits. Whilst there are PHC nurses, there's also a larger number of professional nurses who in fact provide care and often leaned on to provide care, part of their scope, but not necessarily part of their competency. And so they struggle in small clinics and community health centers to do what's required to do. And we hope that in your time with us, you will try to understand their competencies as well as their limitations. The staffing of Johannesburg is more than 3,000, which exceeds that of Chris Hani Barra. So we are the largest health institution in Johannesburg, often much together with Chris Hani Barra. Now, budget-wise, we in fact spend about 3 billion rand, and when you look at it, it turns out to be not a very large sum, but it is not a small sum either. But I think that it compares very much, as I say, to being almost the largest institution of healthcare in this country. So you're in a place which is very complex, not only in terms of the clinical care, but in the organization, and very challenging, I think. The district family physician is Dr. Jimmy Aki. I'm acting on his behalf and presenting this on his behalf. He's on leave and he'll be back next Monday, and I'm sure you'll get to know him. I just want to point out that we really do not have a large number of family physicians around. Often, people expect a family physician at every corner to support the work that goes on, amongst these 80 doctors, 600 nurses, 400 nurses, and across the entire district. We cannot do that. So what we have is family physicians who are responsible for each sub-district, and often supporting from no CHCs to 5 CHCs like in Soweto. So in the different regions, we have family physicians that are in red. Dr. Kazombia is actually supervising in region A. Region B is Dr. Tuluta. Dr. Kazombia, while he's doing that, is actually the lead clinician in region E. So you can see that he's trying to do two things at the same time, two regions. Dr. Michelle Tuluta is the family physician who is in region B. Randburg is one of them. We don't quite get you to go to this place in region B, so she will see you and support you in other ways. Dr. Maggie Petkova is in region C, which is Discoverers, Rudaport area. And then you've got myself, together with Dr. Ruiz in region D, Dr. Kazombia, as I mentioned, in region E, which is Alex. Dr. Kazombia is in region E, based in Alex. And then region F, Dr. Sam Obabuko, but is the family physician, but in most of the people are based in Hillbrow, and they'll interact with Dr. Gloria Malope, who's the CMO there, medical officer of all experience. And then Dr. Ashraf Moti is a CMO, again in region G. So in region G, we don't have a family physician available to support the area. We just don't have enough of them. So there's only two other family physicians who are not on this list. It's Dr. Kalula at Chiawelo, who's running that CHC, but he's not academically linked. And then Dr. Dr. Humain Kabir, who is part of the Chiawelo community practice and also doing work in that space as an academic center. So that's some extent of our family physicians, but these are the people who support care across the whole of Johannesburg. And some of what they do, you need to appreciate, and we'll have to find ways in which you do interact with the kind of work that is happening by the family physicians. They're not just sitting in offices and doing nothing. So we need you to appreciate their challenges. So what they do is that they do provide services after hours. And that is basically, let me just make the screen clearer. In CHCs and also after hours, like I mentioned, Dr. Manda, Dr. Petkova, all of us, we basically are in different spaces providing care as we can. But a lot of the work is about supervision of medical officers. There's a lot of work related to that, as well as interns and primary healthcare workers as we proceed to be increasing that burden. Now that primary healthcare nurses are accepting our role a bit more after many years. We also have quite a substantial burden of teaching for undergraduates and postgraduate registrars. A lot of our work is in fact on clinical governance, and usually these are meetings and visits to different clinics, looking at poorly performing indicators and the way in which we can integrate care more appropriately. Is also the expectation that the family physicians support community-oriented primary care. They do that in differing amounts, but that's a lot of the work which is done in Chiawelo community practice. And I think that is going to be part of our program, which includes community health worker delivering program and case management. And we'll get to showing you more about that as we go along. So the family medicine internship in itself is going to be a 6-month rotation, but as I said, it really is not lots in the CHC. So 1 month is going to be for Barra, and this is what is going to happen in Barra, that there will be 1 month at emergency medicine at Barra, and there'll be a month being spent at the district hospital, which is for the Barra group going to be at Beki Mlangeni, and then at Len South. And that is often the arrangement that I think Dr. Moti has already arranged. Dr. Ruiz will support you in terms of linkages. So hopefully you've been able to link up already, those who are spending the month there. And then there's a 3.5 months acute and chronic care. So your time at a community health center will be 3.5 months. So it's actually 3 months. And part of that 3 months, sorry, I took that off, but let me just be clear, it's 3 months. Yeah, okay, let me go back to that and just share it again. So as I said, it's 3 months of acute and chronic, basically at a community health center. We hope that at that community health center, you'll spend a week at mother and at antenatal care, basically, and child, basically the EPI, family planning. So those kind of elements of the care within the community health center, we hope that you'll be able to visit those places and be part of it. You in your 3 months in the CHC, you will get at least a month of being in chronic care, or wherever it is that it is not integrated. Wherever it's integrated, you'll have your 3 months and deal with all the issues there. If you feel that you're not getting some of the elements of care available within the CHC, please talk to your supervisor to be able to spend some time or see what goes on there. It's something you need to take responsibility to benefit from the experience that you've been placed in. Please do not just enter that space and be said, here's the cue, push it. Do not just do that. Make sure that, excuse me, your learning is an appropriate one. And that learning is not by lectures, it's by doing. You're an intern. So you go in there and you say, I will do work in that space or the other space. But I think we specifically want you to spend that 2 weeks in preventive care. The other 2 weeks of preventive care, you will be rostered to rotate through to CHBAH committee practice. I think we will do that tomorrow as a specific orientation. Those who are in Barra, we encourage you to please do it, to join us there. I think time will not allow us today to do the entire thing, and I think we need to be comprehensive enough. I'll go through it very briefly, but we'll go through it more extensively tomorrow and show you what the experience is going to be all about. This is only now planned for the Barra interns. It is possible for interns from the other hospitals to arrange to do it, but they need to talk to their supervisors to say that they would like to spend time in CHBAH community practice if they feel they're not getting it adequately, and I strongly advise you consider it. Unfortunately, we only have a limited number of slots, so those who come first will get it, and we'll let you know more about the slots. So please talk to your supervisors if you want to come along there. But right now, it's only for Barra. Okay, so I just to tell you, the intern supervisor overall is Dr. Ashraf Moti. He's on the call now, but with the people that you will be with on the ground in the sub-district D, which is Soweto, is Dr. Masiza in Tireleng, who's a medical officer of more than 5 years experience. Zola Gateway Clinic, Dr. Castelvi's got more than 10 years of experience. Lilian Ngoy, Dr. Ruiz with many years of experience. Mofolo, Dr. Ngema, a medical officer, also more than 10 years experience. CHBAH CHC is Dr. Kalula, a family physician. Dr. Ruiz is also a family physician, trained in Cuba. So you've got plenty of experience around you, and usually you'll be with other doctors, but these are your supervisors who will be able to arrange things locally. And if you're at all unhappy, please follow that line of command or communication. Dr. Ashraf Moti will also coordinate the other group from Barrow that going to sub-district G, and they will be based at either Lens Extension Clinic, where Dr. Dudat, a medical officer to 5 years experience, 5 years plus is available, and then Stratford CHC, where Dr. Aziza is a medical officer of less than 5 years experience. So you have people who have got good experience available, variable experience, but at any one time, your intern supervisor is there. You will be placed with other doctors. So these are not just the only doctors available. Okay, so, but they are the supervising doctors. So with the Charlotte Maxeke Johannesburg Academic Hospital Group, You will spend again a month emergency medicine at Charlotte Maxeke. You'll spend a month at District Hospital, South Rand. Arrangements locally will be made by those hospitals. They've been tasked to arrange that to make it a useful experience. Then again, the same thing, you will spend 3 months in acute and chronic in your CHC and a base site, and 1 month in preventive care. We hope that that month of preventive care, you'll basically get to do mother and child for 2 weeks. And if you can, engage with the community health center's ward-based outreach team in that base site. You'll have to explore that in Hillbrow, Alex, and other clinics that you're based at. Again, you can see whether you're getting value or not, but these are not what CHBAH is all about. It is an enhancement of that, but you can decide. Then in terms of supervision, the Charlotte Maxeke group overall is being supervised by Dr. Kazombi Amanda. And in addition to that, you have supervisors at each of these sites. Alex CHC, Dr. Manda is available and will be your family physician there. Hillbrow CHC, Dr. Malope will be your supervisor. Ivory Park Clinic, Dr. Mahamata as a medical officer. And then South Rand Hospital, if you're based there for your month, Dr. Litwawa. We can get through to other sites as well. Then the month of the Helen Joseph have a slightly different arrangement, largely because there's no district hospital in that vicinity, and there is a family physician in the OPD that we've rearranged it slightly. So it's a month of emergency medicine at Helen Joseph. I'm not sure of Rahima Musa as well. A month of HIV in Helen Joseph and Rahima Musa, a month at OPD in Helen Joseph, and a month of OPD in Rahima Musa. You basically have to find the occasion to, in the 2 months at essentially Discoverers CHC, to be able to do acute chronic work in the CHC, as well as explore preventive care community practice there. Like I say, you can discuss with Dr. Petkova, who is at supervising the overall group, about if you'd like to do a patent at CHBAH. The base site in Discoveries, Dr. Mahmoud, a medical officer with lots of years, will be your sort of supervisor, but there are other doctors available in Helen Joseph. Okay, I'm going to run through these, and then if we need, we can take some questions as a bit of a break. Some do's and don'ts. I'll send this out as a full document. It is being used by all medical officers, so it's not just for interns. We expect your hours to be punctual, 8 to 4. We expect you to keep your space, whatever office space or consulting space, to be clean and organized, including that dispensed drugs or dispensing drugs are not lying around in cupboards and willy-nilly about. That's not good pharmacy practice. We also expect everyone to be wearing professional dress, no short pants and slops, and you need name tags. We expect you to focus on your record keeping to be professional and appropriate. It's some of what we will hope to go through. We expect you to follow the guidelines that will be made available to you, and the general approach which you will be informed of by your supervising medical officers or any other medical officer or PHC nurse. Please, this is not just about doctors seeing patients. There's a lot of teamwork that's required. So please be focusing on embracing that teamwork. And there are lots of members of the team, not just nurses, but clinical associates, community health workers. There are a number of other disciplines in community health centers, pharmacy, pharmacists, dentists, mental health, allied health, etc., etc. So please make sure you understand the full range of services available and do engage with them. Others is that we need to have all meetings attended to, and interns will be rostered, and this will be part of your assessment before sign off at the end of your 6 months. We know that there are quotas and arrangements being made between doctors and interns as to who DCs what and how patients are being seen. These are not acceptable, and if they're found, they will be disciplinable. So please avoid yourself getting into that behavior or tangled in that by medical officers. And feel free to report that to the supervising doctors, including the intern coordinators. Please, all leave procedures you need to follow. The details will be in the document. So please think about your sick leave, make sure you inform adequately, don't just disappear, send a message, and then when you come back, provide your supporting documents, fill in the form. And with your leave plan, please don't go off and talk about week leave next week. You'll need to plan that, and so please talk to that. I'm sure that the supervising or the supervisors have already addressed it. Your community overtime, you will already have been dealt with that as to when you're on call, how often you're on call, what your hours are expected to be, etc. But at any one time, it is not okay if you are not supervised. So if at any one time you are finding yourself without a medical officer, you need to inform your supervisor. And if you don't see any response, please go straight to Dr. Aki and copy me if need be. But Dr. Aki will need to address that question, because it is not at all acceptable that you remain on overtime unsupervised without a doctor within reach, especially on the premises. You cannot be told, the person's out. During the day, that can, if you're doing a visit, we can understand that. If the doctor's for one day off leave, that's fine. But you need to, if you're struggling at any one time, you please need to do it. We'll come to the question of how you need to refer and support, but on commuted overtime, on your overtime calls, you can't be left alone. So please communicate, and if you're struggling, follow the line. The line is your doctor in charge who is locally there. Tell him, listen, I'm struggling, I'm not happy. And if there are no responses within a reasonable time, and I would think a week, if you're not having luck, go to your intern supervisor that I mentioned, who is supporting the entire complex, each hospital complex, and you know them, Dr. Manda, Dr. Petkova, and Dr. Moti. If they don't help you within a week, go to the Dr. Aki, he's the district family physician. Okay, let me stop there and see if there are any questions for a few seconds. If you have, you raise your hand if you want to, or you could, and we could allow you to speak, or you can use the chat and the Q&A. So I don't see any questions. Are people quite clear? Are you happy that this is indeed a clear task that you are heading into? Everybody happy? Yes, no. You can also do that. So, okay. Now, I know this is not very interactive. Our plan for teaching and engagement is not to have these kind of very dry webinars with lots of talking. This is an orientation because it's such a large number. We'll have to move towards a much more engaging. So thank you, Busani. Appreciate the comment, and I assume that everyone else seems to be fine too. Okay, so let me continue. In terms of teaching or learning, because you're not going to actually be teaching, we are going to be teaching each other. So we'd like to call it a learning program. So let me just change that. So let me just quickly show you that. So essentially, there is we really value your internship being afforded, a 6-month stint in primary care, because we feel as clinicians in primary care that young doctors need to be ready to understand what goes on in primary care so that they don't find it a disheartening experience. They find ways in which they can cope and thrive in that environment, because our country and the globe is interested in primary care working. And we are very much, as family physicians, interested in making that better remunerated, better rewarded, and we'll share with that with you over the orientation or the discussion tomorrow on COPC and Shawela Community Practice. We basically have that as a model of the NHI contract, and to us that would be why we think it's important that you spend time there and understand intimately how it is that you can set up practice given a capitated environment. So that's what Shawelo community practice is all about. Why all of you have not been allowed to be part of that is, lots of little hiccups, which again, you can discuss with your intern supervisor. But as far as I'm concerned, that's a loss for you if you're unable to go out and join us in Shawelo. So in terms of your overall teaching as a full group, and all of you will be together, we will be having an intern meeting using online. So it'll be Zoom meetings probably. It'll be weekly. It'll be 2:30 on a Wednesday. It will be allowing you to leave your premises from 1:30 to 2 o'clock, hopefully to get home for 2:30. So you can probably get in time. So you can make arrangements with your supervisor about lunch hour and being able to deal with it. So this is effectively giving you the afternoon. And these are 2 afternoons that we are going to allow you to be home and available to have this learning happening. So we're going to have it from 2:30 to about 4:30. We know that some people may have to go off for on calls at 3:30. So the way we're going to arrange it is going to be allowing that to happen, but we'll let you know more about those details. There's still some consultations that need to be held around it. But the important thing is that we need you to understand it's a whole afternoon. For the weekly CPD meetings, this will happen again at the same time, but on Thursdays. We used to have it on a Friday morning and this Wednesday morning, but it used to create a problem where doctors pitch on at work literally at 10 and 11 o'clock, which is really untenable. So we've moved it now to afternoons, and it's much more comfortable. It will work well, and it caters to the fact that at 3:30, a doctor can get back to his call should he need, and so this caters to anyone on call. So we also are going to be talking about quality improvement projects. I'll go through it very briefly. We may have to look at how we support you in that process and review your progress on those QIPs. But it's expected that you as a team in each community health center or setting will have to explore how to implement at least one community quality improvement projects. So please note that. And then in each of these settings, you will be having a weekly case discussion or chart reviews. There'll be some local arrangements, and we will be exploring that you also get to have observed consultations in your settings. And we will also come back to share with you the details of that. But please know that you should be getting a chart review or chart case discussion in your settings. So even if that means you can go along or your supervisor comes along and reviews what you're doing, observes your consultation, and then reviews your chart. But we want it to be a constructive engagement with you, not that you just left your devices in a room and that's all there is to it. There are a number of topics, and this is an expansion of what was done last year. Last year, there were about 20 odd, maybe a little bit more. It was over 3 months, about 20 topics. This year, in fact, we've now got 46 topics, which will be dealt with by each of you. You will basically be taking on this. You'll be provided a link to a document or Excel sheet online where you can put your name to it. And these are all topics that come from your logbook, the intern HPCSA logbook. And these are things that we need you to highlight. And what we're expecting, like we did from the group previously, is that they would prepare and then present. And we then have that presentation. We tried long to get case discussions, but my preference is that we present this week at 3:30 to 4:30. It can be taped, and if you're not available, you can still view it. But the following week, everybody should be familiar with whatever has been discussed or presented to you. Then we go into a case discussion where the team that leads that topic together with others will in fact have small group discussion with a case that deals with that particular problem. And so we need some very creative thinking around cases. How do we find a way in which we can create a very interactive learning? And so these are not just for you to to just present these topics. It's about how you learn and how you teach. This is in itself part of the equation in this process. So each of you will get an opportunity, and that in itself is a very important exercise. So as you can see, there are a number of things in this list of topics. I'm not going to go through it, but we expect you to start adding your names and taking these on. This goes for the full 9 months. So once you're more aware of your rotations, you can then pick your topics, and we'll give it at least until the 20th before we start, but we'll need these to begin in the next week or two. So we'll send out emails to make sure you are clear. As I said, we can't have a person per topic because you'll have too many for 46 topics, but there are actually 120 people. So we're looking at 2 to 3 interns per topic. We expect you all to work on the topic together and then share it and present it together. And we will be having question and answer sessions. And we expect, that you respond, all of you respond and support it. It's not one man's job, one person's job. So the first session, as I mentioned, will be on the 20th to give you time to get yourself together. I'll send that Google link. As I say, the presentation, and we'll try to do that that 20th, is that from 2:30 to 3:30, based on some of the work that I talked to today or tomorrow. You'll be doing case discussions in groups of 10 the next time we see. I'll let you know more of the details. And the idea is that whatever we do this week is available all the week. And then you, as a team of 2 or 3, get another couple of people who will then become leaders, facilitators in these discussions, and provide that to me so that we can put you on the group and just organize it better. Okay, so that's basically the do's and don'ts and the way in which your learning will occur. We also want to go through, I think, important principles and that you need to understand. So this is, in fact, some of the content issues. What exactly is the difference between you as a clinician, taught lots of common things, and what is expected of you in primary care? And many a time, lots of the expectation is that of you being a competent clinician. And yes, it's just as important. And it is something that we need to talk to as exactly how competent are you. A lot of the times young doctors come out more competent to deal with specialties than in fact what is common. And yet the expectation is that as a young doctor, you need to be really very, very skilled at the common. And that's not always the case. So lots of the time we have to retrain as family physicians and as family doctors. We have to retrain people to think more appropriately, even as clinicians. But there are other tasks. So as you see on the top, these are the 6 roles of a family physicians, and down bottom, the family doctor as expectations after a diploma in family medicine, which is a 2-year distance-based diploma that's come up in a few universities, and that I would encourage you to consider in your ComServe year. So this family doctor, family physician is about clinician being able to provide care, but we also expect family physicians to be building capacity. And you can see that's the 2 things common to both. It's about teaching, supporting, mentoring other practitioners. Now, here you're going to be mentoring each other, but you also have to be learning how to mentor nurses, clinical associates. So on the ground, we, in fact, in these case discussions, would want you to bring the nurses, bring the other clinicians together, and in fact, find ways in which you can build their capacity up. And these are some things that we would encourage strongly. And it should be on the ground with CPD meetings or teaching meetings within the facilities, that they're at least having a CPD or some sort of meeting where there is a team-based teaching going on. We need to engage in that. There is also, I think, the clinical trainer, which is more postgraduate students, which is seen as the academic role of the family physician, and in fact the consultant. Now, if you look at it, often these are sort of different paradigms, but there is an overlap. Consultant, as a family physician, or a family doctor, you have to work with the others. So you're not just teaching your team, you're actually sitting with them. And if there's a need, they come and ask, listen, what's going on? How can I, do this better? And in some ways, you may also be doing that because you may be asking them to help you as a consultant. So if there's a nurse out there who's actually doing TB, she knows a lot of what goes on in TB. And it is important for you to actually say, well, how would I do this or how would I do that? It might also be that you are a consultant to allied health workers and doing the same in reverse. So that collaboration consulting approach is actually very important. Now, critical thinker, and change agent are just elements of better thinking, and how do you use your opportunity to be a better clinical leader. And that speaks to the question of clinical governance. Now, at the moment, many of you as interns don't even have a sense of the kind of work that's involved there, where many a times it is about creating protocols, it is about ensuring quality and about quality improvement, about supporting the administration to function with appropriate care or systems that do not undermine the clinical objectives or the quality of care. It includes trying to look at quality of care, not just clinically, but in terms of some of these programs, whether chronic care is being managed appropriately, whether even the expanded program of immunization, whether that's being done appropriately. It's whether the COVID system of triage in our community health centers and clinics, which we as family physicians have tried to provide support to and lead. These are all providing clinical governance. They are providing clinical leadership, and you need to be able to do that by being a critical thinker and being able to say, how do I make change? So these are all, as I say, very overlapping ideas. The last one is that and it features very strongly, that the idea in family medicine is that you think more about community-oriented primary care than is commonly available. Now, yes, these terms that are being used in front of you are talking about champion of community-oriented primary care and community advocate. But if you have the opportunity to listen to what I talk about in Shawelo community practice, to me, it is not just about an inclination towards community. It is about how do you look after a population in its entirety, and how do you think that through in a new payment system that may come along. So you won't get that very easily in your current exposure, and even with this kind of practice in many of the community health centers. But this is an important part of what a family physician and a family doctor is trained to think about. How do I not only work with the team in the clinic, see patients, but how do I think through systems as a clinical governance, in my system at least, how does it work? But also, how do I think not just of the system being limited to my patient base, the patients who walk in, but every single person who is enrolled to be in my practice. And that concept of empanelment, enrollment seems rather strange and foreign to us right now, but it may become part of our normal thinking within a few years or months. So I think that please know that the NHI is being pursued actively by government, and community-oriented primary care is a very important element to try and change some of the equation within a NHI contracted by capitation system. You need to understand these little issues, and that's what, as I said, Shawelo will be about. So in terms of understanding principles, these are the roles, this is what we have to do as we are employed and work. But family medicine and district health principles, often people will talk of family medicine principles, but they're actually district health system principles, which are there in the National Health Act, laid out just what are these principles. And as I said, they overlap quite considerably, but importantly, and this comes from its history, that often family medicine as a discipline tends to be me sitting across the desk of a patient. And so these are the elements I talk to. And I think most of you remember this from your medical school training, that I need to pay attention to the subjective issues, which is how do people think and feel that's important, how I think and feel, not just keep ourselves to the objective, clinical examination and history taking, but do I understand what's going on in this person across the table, and not just them in themselves, but their context, and what's going on in their family and their work, etc. So you understand that. I'm sure you also understand that, family medicine is not just about a particular set of diseases, like pulmonology or, into dermatology, etc. It is about the person, and the disease is just part of that mix of dealing with the biological, psychological, and social. And this is really this idea of think about this. How am I dealing with people? Because in primary care, the biological tends to be sometimes, you might say, boring. It's just the same old clinical problems. The complexity does not come in that. It's the fact that you're seeing so many, but that you're seeing it with a whole lot of complexity around the patient, with their individual thinking and feeling, and then that context around them. So that's the difficulty you have to negotiate. And as I say, it can become hugely more complex than even the big specialties. So you need to think about it. Even in the question of individual interactions, contact prevention, you basically want to use the opportunity to prevent and promote. But there is some elements of context, in other words, system context within family medicine principles, which if you read about, you'll see, that are important, that people don't realize, is part of family medicine. The idea is that a good family doctor would be one that is not abstracted from his patient's living experience. So, if I'm a GP or a doctor, it's usually expected that as a family doctor, I'm not in this abstract hospital just moving around in a space that's not aware of people's living experience. I'm actually in the same community, in the same place. I use the same shops. I use the same, other services. I'm part of it. And that makes you appreciate this lived experience of your patient. You share that. Then in that process, living in that space, you actually know a lot more of what goes on in the community, and not just medical resources, but community resources. Where the social welfare offices are, who is that, NGO that's providing XYZ support to the community, or that church that's very active. You'd usually know that, and you should. If you don't live, and often we don't share habitats with our patient, so we need to overcome that difficulty by going out there and trying to understand that habitat and to pick up on this community-wide network. In the settings of primary care and family physicians, the expectation is that we, in fact, go up to hospital care, and that's what family physicians are trained to do. But the diploma trains you to be good at least at the office and into the community, both the family physician and the family doctor, or to be able to take care into the community. Now, sometimes, that may not be possible, or it may be possible in other circumstances globally, but you can still take care into the community, but it doesn't mean you have to do it. So in Shawelo, for example, and with the CHC program, it's the CHW program, WOBOT program, is about finding ways to take care. It does not happen very well at the moment in the current public service. You'll have to go there, engage, and see. What you may see is not very impressive. There is some of it happening, but the idea is, how do we engage at a home level? In Shawelo, we are actually actively engaging in it, but through the proxy of community health workers. The next point is actually a very important one. It's that in family medicine, as a principle, you're not dealing with just patients. You have to think the population at risk. Now, the population at risk is, you may think, risk populations, where you sit and say, who are at most at risk for disease, and you can target them. But to get to know that, you have to know the population overall. And in many respects, lots of the work around WOBOTs and the Shawelo community practice is about knowing the whole community. Now, that's an enrolled population. I'm not going to get into the details of it and how that translates into the future NHI practice, but you have to know, how am I knowing who is out there, and am I dealing with them appropriately. So I'm really targeted. I'm not just sitting here and waiting to get that CA cervix from that woman who just never did a pap smear. I'm actually saying, who out there has not had a pap smear? Let's make sure they get that pap smear. And then you reduce that kind of burden of care to you and the overall system. Now, the second last point is that resources are utterly important, not just in the capitation system where you'll be given the big sum and told, manage it. But generally, you have to think resources. You have to be appropriate. You have to think, do I need this? Is the evidence supporting it? That I use, for example, remdesivir in COVID, when in fact the evidence doesn't provide it. And yes, even the resources, you might say, well, I can't do it because the system doesn't allow it. Do I tell the patient to buy it? Those resources are still resources. So you have to think carefully. Medical aids are still resources. You cannot squander them. So we have to think resources, and this is a big element of what we train in family medicine, is for you to understand how to look at these issues a little more closely and to make informed decisions, even at a system level, if not at a practice level. The last thing is that we expect everyone to be a lifelong learner and to be able to not only learn, teach themselves, but to learn. And it's something that we try to get you in this 6-month experience. Now, as I mentioned, there are district health principles, and you can see they come from a contextual issue, but there's again a fair amount of overlap, or a bit of overlap. You have to just see where that overlap occurs. But I think it's again in the same setting of a population, and the way in which a non-clinician manager, public health practitioner tends to say, how do we see the system delivering better care in primary care? And the system says it wants to improve access to service. Can people get care when they need? And that's an important question for you to ask. Are we actually accessible? And there are lots of constraints to accessibility. It's not just about the physical distance to a facility. It's about affordability, because at the moment, yes, services are free, but in fact, because clinics are not within 5 kilometers, there can be a problem. They have to take 2 taxis to get the 5 kilometers if they're not well. And that itself can cost them a whole lot and be a big impact on their income. So these are still questions of reduced accessibility is affordability. Acceptability is another notion that's really important. And I think many of us personally feel that, that's the kind of challenge that is there. Are people happy with the service? And there's huge challenges in terms of access on the basis of acceptability. People don't like it when they come there, and that's why they go away. A public service right now is not accessed as much as the Department of Health would like to. They expect visits or rates of 3 to 4, and right now in the public service, it's 2.5 across the country. So we are not getting the kind of access, and people are having to pull out of their pocket and go elsewhere, privately usually, to get service. And that is an indictment of the system. But the system says it wants that. Equity, and I think equity is not equality. It is about not giving everybody the same. It is about those who need more to get more because the need is greater. So it doesn't mean that, it means that where we have very challenging populations, that in fact we have to put more resources into those places. And I think there are ways to work out that can be done. But it's an important principle in the health system. Integration is there as a principle. Unfortunately, and everybody wants to overcome fragmentation, but the notions of integration vary. Often managers think how to integrate around themselves, not patients. And I think that often at time they will say, well, I need to integrate everything where I deal with it, but we will create systems that will help me to have everything easy done. So we create these various systems within clinics. And so we've got very, very fragmented primary care services that are integrated around a clinic, but actually very fragmented in terms of the experience of patients. So to me, the primary goal of any integration must be around the system, the person, the patient, and the person. And I think these are subtleties that are often missed by practitioners. Community participation is again part of the principles of the district health service. very poor. Even the community hardly ever gets to be engaged with very much. You should be inquiring at the clinic as to what is the level of community participation, what are the pros and cons of community participation. Many a time, the extent of community participation is that there's a clinic committee that has been elected from the community, and often not elected, actually nominated, politically linked and then nominated, and who serve as the link with the community. And in fact, it turns it over on its head. Instead of the other point being local accountability, where the community is in fact using these people to hold the clinic itself accountable to the community, it turns up the other way. Usually these people as clinic committee members are almost co-opted by the managers to become queue marshals, to become the face of the clinic for all its unpopular decisions, and then to enforce those decisions, and then to be able to, simply deflect the attention from the facility manager themselves. So to me, there's enormous challenges with community participation, local accountability. So I think that is something you should be asking. How would I, if I were, as we hope you will do in Shawelo community practice, is how do I set up my own practice in an HI contract and actually achieve these things? And this is something important. Now, included in this concept of district health service is the question of developmental and intersectoral. Now, this is often missed. We have literally no evidence except perhaps a facility manager running to the police station to ask for help when there's a case. Sometimes there's school health nurses who go out, but there's not much strong interaction with the educationists out there. There is sometimes the community policing forum that interacts with the clinic managers, but this is marginal. That's about it. Otherwise, there's very little developmental intersectoral work that happens happens currently, but it's something that's really important. And this needs to be thought of as part of the equation when we're looking at social determinants of health. And in CCP, it's kind of some of the stuff we look at on a month-to-month basis. How do we explore these things? They're not at all easy, but they require very strong focus and engagement with communities, and it can unfold if you're happening like that. Decentralization is a principle, but you can see within the health system right now, lots of the ability of managers is not there. They have a budget that is in fact a paper budget. Ask them about it. Can they buy with it? Very, very little, if anything. They have a petty cash that they might be able to use. Otherwise, all decisions are made, some of them are made at a sub-district level, quite a few are made at a district level, and even more are made at the provincial level. So decentralization is very low. There is a push in the Department of Health for stronger decentralization in preparation for NHI. Capacities on the ground, though, are very limited. So there's a huge sustainability problem, and I think that's been part of this whole challenge. How do we actually put in systems that do sustain itself? And at the moment, there are difficulties around it. We need to be able to explore, at the moment, I think there's a lot of waste in the health system based on lots of managers who are managing managers, and that's all their job is about, or people who are sitting around and doing nothing. And I think you must look around yourself while you are there as an intern as to what is the best use of resources. And if you were to be part of a new equation with the NHI, how would you do it differently? And I think these are some of the questions of sustainability, that there can be different health systems set up, that primary care systems based a lot on doctors, that's yourselves, who can do a far better job with more effectiveness and efficiency. So I think these are all the sort of numbers bits that you need to look at and understand. These are principles that are there, and hopefully you get a sense of these. There's a very little focus on the individual. They try to emphasize quality and comprehensive services, but I think that notion of quality is often just guideline, very reductionist guideline adherence. And I think as you're sitting around, ask people about what are the indicators, what are the measures of quality, and you'll see it's very much the input based. How many condoms did you distribute, not how many people have we actually improved, in terms of infection rate, or you'll see the indicators in terms of numbers of people adhering to HIV or ART, quite a challenge. So I think look around and you'll see lots of these problems. Are there any questions? I could stop for a moment and take questions if there are any. I see on the chat, these topics presentations shared. Yes, Maria, the topic presentations will be shared amongst the 3 hospitals. So all of you will get the link. You just go up there, and perhaps we'll put the link with the hospital so we can see that it's spread, but we'll actually indicate which hospitals will take it on, which section, because there are some variations in the rotation. So we'll just try and help it along a little bit and make sure it's distributed reasonably. Okay, any questions around the question of, or the issue of principles of family medicine and district health services? We're going to, as I say, do this case discussion where I share a case and you're going to have to discuss these issues in groups and see in the case itself, what are your thoughts? So please don't forget this. This is not in through one ear and out the other. Okay. I'm going to do the 1 or 2 next few things if there are no questions and no hands up. Very briefly, but I think we're going to have to do this another time. I think we can go up to 4 o'clock, but I think for me to talk for 2 hours flat is really challenging, especially with everyone on the other side potentially sleeping on their desk. So let me just go through these a bit more slowly or quickly, and then we will come to and do the rest tomorrow. So with that, I'm going to go through the next bit, and this is important also to the question of your experience as you're seeing patients in primary care. It is it is something that you should be, as young doctors, be getting much more family medicine training happening within your undergraduate training. You might have come across different methods of consultation or models of consultation, things that can help you to consult. Every one of you understands, I take a history, I then examine the patient, and then from there I might explain to the patient. And that's your basic, not consultation, but your basic approach to patient. Consultation is more about engaging with the patient. It's the same process, but it's what you do. And there are different models. Some of you from different universities might have had experience with different things, but this is one that's been developed by Prof. Hugo from Pretoria and Prof. Cooper who's now at UCT, Juggler's model. And I like it very much because it's very simple. There are others like the Calgary-Cambridge model, which some of you might have experienced, and I'm not sure that you find it helpful or even remember it now. Most of you seem to remember the Stotts model, which talks about the question of help-seeking behavior. Well, more than that, firstly, what is the presenting problem, which is patients talking about? What are ongoing problems? In other words, other problems that are going on, which are usually chronic. And the third one is the help-seeking behavior, which is, more what are the kind of, when you're having a battle with the patient, why have they come to me now, which is important. But the most important, valuable one, besides the time associated or the chronicity associated with an acute or presenting an ongoing problem, is that of health promotion. And this is opportunistic health promotion. It's about saying, don't forget to ask a patient about the kinds of things that are not routine or not expected in this consultation. So yes, I'm seeing a patient and I might deal with HIV and talk about HIV prevention, but I need to not forget this is a lady. When did she have her last pap smear, even though she's come with a cough? And this is the opportunity to think, and that's the idea of the model. So Juggler's model is, as I said, a relatively simple model, And essentially, there are 4 elements to it. I'll start with the easiest one. It's about time. Time being, you haven't got time to waste. You need to actually do things quickly. And time is often not the reason for you to say, I can't do a consultation properly, a family medicine consultation. In fact, often time, if you have less time, it's the clinical tasks that are reduced, that are neglected, not the family medicine approach. Because the family medicine approach starts minute 1, second 1. As soon as the patient walks in, if you have a family medicine approach, you'll be applying it. And it doesn't matter if you haven't got time, you might cut things short because of the time your problem will you'll cut the clinical task down and deal with what's priority. But your approach to the patient won't change. And that's what's important. So let me start with clinical reasoning. This is actually something that many of you as young doctors, as young graduates in your 6th year would have been battling with. Moving from the paradigm where you are sitting with, a ward-based approach of clerking. Listen, you have to get all these questions. Don't forget this and this and this. You have to remember all these questions. Once you collected that information, then you sit back and you think what it is that I need or what it is that I have as information to then make a diagnosis. Now, in clinical reasoning, we try to get you to appreciate that is what's called inductive reasoning. It's what you do in the hospital. It's what you do when you're battling. But in usual primary care, good quality primary care, not shortcuts, is what is called hypothetical deductive reasoning, or what you might call patterning, what I call intelligent guessing. And intelligent guessing is probably what you already are starting to do. So if you've been there in the medical wards, you've already noticed that when the consultants are talking to patients, they're not doing the full clock. They somehow stepping ahead of the curve, and you kind of follow that routine. You need to know that that is appropriate. In primary care, that's very appropriate because you cannot manage all the systems like every specialist does. In primary care, you've got to actually think through with a hypothesis at the beginning. As soon as the patient walks in and you even see things, you can begin to say, oh, they look like they're coughing. They look like they've got a sore back. You might see things as soon as they open their mouth. You might hear things they talk about immediately. You're already starting to think, what are the possibilities, but what are the probabilities? So you are actually thinking risks through. You are thinking probabilities through right from the moment the patient walking in. And that is good. It is, if you're going to, and the risk is that you jump to probabilities without thinking all the possibilities properly. So you need to balance that probabilities to possibilities. So possibilities is, well, what could be possible in this situation? And you got to think of those that are red flags, things that if you miss are quite dangerous, or what's common in primary care. Those are what you're going to think is possibilities. But it could include the things that are rare. But then you got to now say, well, hang on, now I've got to think probabilities. So probabilities is, no, hang on, what's common? What I expect in this kind of setting. So you need to think very practically. And that is going to be, as you're thinking the possibilities and probabilities through, it almost guides you to ask your next question. So you're not going to roll out all your questions. You're going to go sort of feeling your way around and saying, well, that system not involved. I'm not going to this system looks like marginally involved. I'm going to focus on that towards the end. So you're going to focus on the systems and then the particular symptoms, because you want to try and have differential diagnoses with which you can start dropping off the possibilities to firm up the probabilities. And then finally, if you're lucky or good, you can actually get a high probability that you can say, this is what it is, and this is the problem. And you might say, well, listen, there are the things that are probable, but and you might manage them otherwise. So this is the idea of clinical reasoning. And in that process of taking history, that is what you need to be able to apply. And I think in that process, I would think you should put in, when you're talking about social history, which is really important to get at least a feel of this person, and their context, their family and community context, that their social behaviors like alcohol drinking, etc., and then think of the issues of opportunistic health promotion. So I like including, that STOTS model in there, in that opportunistic health promotion. Otherwise, the presenting problem, the ongoing problem kind of unpack themselves within the history taking. Now, these two elements of facilitation and collaboration, they're actually very important to make you the kind of doctor that is not just this narrow clinician, who disconnects, can't deal with this person in total, even collecting the information. Facilitation is really about listening, keeping yourself opening, and sometimes you need to check yourself how long it is you give the patient after your opening question, introducing yourself, asking their names, tell me how can I help you. Then watch yourself. How long is it before you interrupt the person? And if you are dealing with the patient, often we hear the first complaint, we want to dig in, tell me how long, etc. You need to just back off. And I think this is the kind of teaching that we need you. We need you to be a good consultant, a good provider, clinician. And that means to give the patient the opportunity to speak, allow them to air their views, let silence be there, even if it's pregnant. And then also do summaries, tell them, this is what you told me, is there anything else? And allow them to unpack it and give them at least a minute or so of that time to be able to share what goes on. So I think hearing the patient to say things in their own words, and don't try to clarify immediately. As you then let them unpack, and then you've got at least a set on the table, you can then organize it and then start saying, listen, you said you have a cough with this and this, sputum was dry. Tell me more about it. And if they told you they thought it was TB, you can then explore. But importantly is let them start with open-ended questions before you jump into closed questions. So this is the progression of good facilitation. Okay. And it is a lot about at the beginning to be quiet and to listen. As time goes on, you're going to do that less because you have time to manage, and depending on the circumstance, you're going to try to manage that appropriately. But by listening adequately, you will actually be able to navigate your time hugely better. An example, many people say, well, if I ask the patient what's next, or what else, they'll tell me all these long stories. There are very few patients that will do that. Most people actually struggle to even tell you a few things because doctors are mostly nasty by just cutting them off. So you may find the occasional auntie, Indian auntie who gives you 10 things. If the number 10, you can say, whoa, auntie, hang on. You've told me so many very useful things. You really have been very helpful. We don't have time to manage that. Which do you think of these 10 things would you say are priority two? And then we can try to deal with the rest another time. I think auntie will not be upset because you've told her that you've told me she heard you. And I would say the 10 things, these are the 10 things you told me. She'd hear you say them back. She'd know that you are going to give it time, that they're all important. You're telling her she must choose. And then you said you'll come with it later. No, auntie will be very unhappy with you. So I think this is a way to even shut it down, but it's a very good way of opening it up. So facilitation is by no means patient-centered that is gone awry. People sometimes let a patient walk all over them. That's not patient-centeredness. You've just lost control of the community, of the consultation. So please control the consultation, but you can facilitate at the beginning a lot, and it can really make a difference. And it can help you to chart your way. I mean, many a times we find a patient doesn't share very important things at the beginning, and then at the 8th or 10th, 12th minute, they suddenly tell you something that's going to require a whole lot more time. And you've wasted a lot of time on something that was relatively minor. So this listening capacity, active listening is really important. And I like using the word active listening instead of facilitation. But the model is that. The collaboration element is about how do I work with this patient? That's what collaboration means. But to me, the better word is how do you empower this patient? Because to me, those are the elements that I like to focus on. And there's a mnemonic I like, or an acronym, whatever you call it, that basically says, I squared, and I want to listen for this. I don't need to ask for it, but I want to listen for it. And if I don't hear it at a later, before I get up to examine the patient, I want to ask them, what do you think is going on? What is their idea in their head of what's going on? Some patients say, listen, doctor, I don't know. You tell me. No problem. But do you have any idea? No problem. They might have some idea, let them share it. If they have already shared it with you and you heard it, ask them, you said that earlier on. What do you mean by that idea? And that idea may come in very, please watch for it. It comes like, I'm not sure whether, my uncle has diabetes, and they might just drop it in there. So you need to be listening for that, their ideas of what's going on. The C is to say, what are their concerns? What do they feel is bothering them? And it's a feeling. So they might use words like, I'm worried, I'm stressed, I'm not sure. You must look for emotive words. Don't anything that suggests how they feel, and listen for it. If you don't get it, ask, how do you feel about what's going on? Not just what you think, but how do you feel about what's going on right now? They might tell you again, I don't know, doctor, you're the expert. No problem. If they tell you if they use words that you have explained it and you're not sure, even if you think you know it, ask them, what do you mean? You'll be quite surprised sometimes when people don't quite mean the same things by saying, I feel disturbed. What that means for one person isn't necessarily the same thing for another. So please ask them, what do you mean? Then it is E. Now, E is actually expectations. And this I don't use, but I think it's something that you should ask. What would you like from me today? I use it when I'm confused, but as I say, I think it's something you should use more often. Where at a point before you are getting up to examine, you might even ask it at the end, where you might say, I've done all these things for you. This is the problem. This is the solutions I'm giving you. Is there anything, any problem with it? But is there anything else you want from me? And that is when you can deal with it at the end of a consultation. But to me, that ICE is very important, your idea, your concern, your expectations. Then the second line of ICE is the ICE, but C and E is in fact complementing. Now remember that this collaboration grows. In the beginning, it's less, but as you grow through the consultation, towards the end of your history taking, and in fact, even to your explanation, you're beginning to start managing the patient, and managing using yourself as the drug. It's your explanation, your information you're giving, your reassurance. These are becoming part of it. And in a way, as you're going along, you're also asking the people what they think and they feel. So compliments become an important part of that. So when they tell you, yes, I think I have TB, what do you mean? No, I've been coughing, it's blood, my relative knows about it. This is not necessarily common knowledge, and you should not hesitate to compliment. You look like you really know a lot about TB. It's very good. You want to enhance, you want to build their self-esteem, especially around things that you would think as good behavior, as important behavior. If that mother cares for a child, you should compliment. If your father cares about work, you should compliment them. If the the young person comes in and knows their medicines by name, you should think to compliment, because these are not actually what the average patient has. So do find a reason to compliment patient. It builds self-esteem. It makes them much more amenable to the kinds of things that you would perhaps say. And it's part of the psychotherapy or cognitive behavior therapy that you might engage in, or motivational interviewing. Then the E is about empathizing. And this is really strongly part of motivational interviewing. It's about how do you provide people, and empathy is really about how do you put yourself in other people's shoes. And many a time people struggle, how do I do that? And I mean, people don't feel comfortable to empathize. We do that very well with our friends. Friend tells you, I hate my gym. You'll say, I hate it too. Yeah, it's terrible. It's just natural for you to feel at one with your friend. even though you might enjoy it more than he does. But that's how we build friendships. That's how we build connections with people, by putting ourselves in their shoe and letting them know that I feel what you feel. Patients need the same, but we are very uncomfortable to do that. We feel that, no, but that's saying, if they tell me, no, I like my alcohol, I can't empathize with that. But why can't you? I mean, lots of you might be drinking and you know that alcohol's nice. It helps you relax. No behavior, no lifestyle choice comes without benefit. Yes, the harm might outweigh the benefit, but there's a benefit nonetheless. And yes, the harm might outweigh under certain circumstances. Like you might say, oh, well, this is tough. Why are they stopping alcohol? It's really not that harmful. Well, that's a debate out there. But you need to understand that when you talk to patients, you need to be a human being and you should be able to empathize. You know what? I like fat cooks. I can't stop them. Yes, they're delicious. You should be able to say that. Oh, yeah, they're so delicious. I don't know if you've tasted fat cook, but it can be very delicious. I haven't tasted one in a while, but I know people love it and it can be delicious. You don't need to lie, like I don't drink alcohol, but I can say, yes, it can really relax. Doesn't mean I'm lying. I don't know it, but I'm saying it as if I'm experiencing it because I know it's how it is. So empathy is something that it really transforms you as a doctor from a good to a great doctor. And many people struggle with that. They see doctors who are just not empathetic, who are not able to put themselves in other people's shoes. And I think if you want to be a great doctor, it's something you need to master. Now, this is basically the whole story around, well, not the whole story around it, very quickly, around consultation. And I think that we will use some case studies around this and maybe a video too for you to look at and to critique in the first session on the 20th. And I'll let you know more about that. The next thing that I want to just go through quickly is the QIPs. You will be doing that. We will be talking more about it, but I thought I'd just share with you some element of it. We will do this again in a way that is easier for you to do it, because you're going to have to think around topics within your setting, and I think hopefully this will give you some idea to begin thinking about it. What is your group going to do? Now, you'd be surprised that there's so much of research about new knowledge, but if you go around now and do a search on what is the quality standard for HbA1c outcome in primary care in Africa, you'll find zero research or a few here and there. If you're looking at some basic stuff like assessment of quality of blood pressure measurements in the public service, you'll find practically nothing. So we have lots of knowledge, but the way it's being implemented is hugely problematic. And so we are wasting knowledge, wasting our time gathering new knowledge, when in fact in the system of healthcare, knowledge is not being implemented. So quality improvement is about taking what we see as this is clear knowledge. Are we actually doing it? And can we make sure we do it properly? So this is what it is about. And we do need to focus on that. In terms of dealing with quality improvement, there is an element of thinking about it like research, but the idea is that it shouldn't be taking a whole lot of things and becoming, research in itself. It's not asking a whole bundle of questions. It's actually a dipstick, but we must try to, like research, make sure it's not rubbish, that we think through the questions of validity and reliability in the way we do something. So these are things that you need to think about. What am I actually measuring? And am I doing it right? What are the tools we use? So it still doesn't mean it needs to be sort of simplistic. It can be simple, but it doesn't need to be simplistic and false. Truth is what we're after. So how do we go about this? And these are three to four elements that we would want you to think through as a group, and that's the community, the interns at each CHC or clinic. You have to ask yourself, where am I looking for? Quality problems are all over around you. You look around in your first week, in fact, you probably saw it even today. But if you look around in your first week, you'll see quality issues galore because primary care is challenged. But it's about how do we try to look at that? So where's the criteria? How do we decide what's quality and what's not? Criteria coming are not from journal articles, they come from guidelines. Guidelines are often an assimilation of all those studies out there, and strong evidence-based studies that are assimilated into a guideline, often developed at a national or a regional or global level. And in national level, it might be a national guideline, or it might be a national society guideline. So there's a number of different guidelines. There are even guidelines for facilities in the ID clinic manual. So you need to look around you and see, well, if I see a problem there, how do I see what is supposed to be done? If I'm not sure, that doesn't look right, I should go double check. Let me go double check. What is the criteria? And that's the guidelines, okay? The next thing is, of course, is, I'm now reading the guidelines. You've got to say, well, there's a whole lot of guidelines. In quality improvement, it's not about taking everything and trying to change everything. You've got to pick up, now, you know what, let me do something simple. And this is the key thing that makes it different from research. Let me take 3 to 5 things that I will count as well in very simple ways. Now, you can do it qualitatively as well, but I'd strongly advise a quantitative approach. What can I count that I can say it's there or not, yes or no, to make very simple questions, or this is done or not done, to find easy ways to capture all the information, to find a way to assimilate all this into a way you can measure. Well, this is the percentage of that indicator. I can actually see and count how many people have had an HbA1c done amongst all my diabetics who are presenting, who are not on insulin, or who are under 65. Based on the guideline, that's whatever it is you have, that's the key. And that's where the important issues of validity and reliability, of thinking through what exactly am I asking in that indicator. And this become very important because you may be pushed to, in fact, do quality improvement projects as part of your small practice when you contracted, or even with CPD. So this is something that can be very, very helpful and important. It doesn't need to be complicated. You just have to understand it well. So you can think through, well, listen, how do I gather information in which I can just say, well, here's my 5 things or 3 things that I need to just check on my files. Each file I go through, I find a way to randomize the files out of the population of files. I then look at getting this information, tick done, no tick if it's not done. And that way I can come out with, this is the achievement in that particular setting of the indicators we are looking at. All said, well and done. Then what you have to sit and ask yourself, well, what is the expectation? I mean, if I see 50% of patients have had a urine examination done amongst hypertensives in the chronic clinic, what does that mean? Is that good? Is that bad? And some may say, well, 100% should be. Well, the reality is that 100% isn't the ideal. It should be, but that's not what is in reality. And well, how do we know what reality is? Well, you have to go into the literature and say, well, hang on, let me just look in the literature. Where are there studies that have been done that look at the indicator of urine examinations being done on hypertensive patients, and how many patients have had their urines done every 6 months in primary care? And you'll be surprised. Firstly, you won't find these studies. Secondly, when you find them, you realize, well, hang on, it's not as good as it is. And so that's where you're going to pick up. And you'll see, well, the best that was done in the global setting was 60%. And then maybe you find something in South Africa or Africa done at 40%. Well, you might say, well, listen, depending on where I am, if we did ours and it's only at 10%, you might say, well, let's set our standard at 40%. Let's aim for 40%. So we are going to now look at a quality improvement project. We're going to look at the team, say to the team that's in the clinic, listen, this is what we found. We need to make an intervention to try and change this because this is clearly problematic. It's not according to the criteria. We've done this very validly. It shows this problem. We looked at the literature, and in terms of standards, we are way off. We need to improve. How do we do that? So together with the team, not you, the entire relevant people of the clinic or the community health center need to debate that. How do we actually change that we get these bunch of things that we've seen as challenged in our setting to be improved? And with that, you get a buy-in, and this is really important. Without the team, you can't do this alone. It's not for you to do some nice thing and walk away. Its sustainability will be that you are supporting the team to do it themselves. So that is what we're expecting you to do, and we are expecting you to work strongly with the doctor in charge at your facility, and he should be in fact taking responsibility. So ensure that he's actually not just leaving you to do all this. You need to work with him, and you need to take charge of it with you to make sure that it works. So teamwork is very important, and you'll then make some intervention. Hopefully you will be starting to do some meetings and processes in your particular space. We will try to engage with you on a monthly basis to say, can we get some shared discussion about what you're doing, what's happening, how is it progressing, what's going on, and then hopefully as you've intervened, you make an intervention, and then you do a post-intervention audit, and then you'll share that hopefully before the end of the 6 months. And it'll be a team-based effort, so obviously people are going to be going away and coming back, etc. It's not a deal, it's a team effort, so there's always a bunch sitting there, so they can all together try to manage it. It's a group effort, so please make sure that everyone participates. So this is what our quality improvement project is all about, and I don't think that should be overly complicated, but we will look at having a discussion a bit more closely on the next one of the times when we meet. Now, I don't see any questions yet, but sorry, there's one question on the chat if you want to add some here. Yeah, I am going to be leaving now. I'll close in the next 2 minutes. So this thing is recorded. So if whoever has to leave, they can find this in the next few days on the website, and I'll send the link out. It'll be on profmusa.com, but you'll get the link, and then you'll see where it is. So you can go to it and get the presentations or anything that's missed. You'll also have the presentation, so you can scroll forward to whatever you need. Okay, so in terms of the last one or two things, referrals, we strongly urge you as interns to please register on Vula. When you register on Vula, unfortunately, I should try to show you the screen. We'll maybe do that at one of the meetings or tomorrow. We'll show you what it looks like, but it's very easy. If you follow this link, and just click on it, you should get to a register page. In it, when you're filling in your details, it will ask for your workplace. Please look for family medicine. It'll ask for team, your team or department. It's the first one. So please, it's not for CHC, it's for department. So in the department, you please need to fill in family medicine. When you do that, you'll see a whole long list of facilities. You'll see yours, please join it. If you need to change this setting later, if you go on the login page, you'll see national, referral and national, go to Vula testing, which is the last one. If you're still struggling with any of this, you have those contact details, which you can follow on. Okay, COPC, I'm going to do tomorrow. So we're not going to talk about it today, but it's a lot about how do we actually prepare for a contract with the NHI. And that's for tomorrow. That will be at 2 o'clock. It'll be probably an hour and a bit, but it will be to prepare for all the people who are coming to Shewelo Community Practice need to be there. That's the Krisani Barra group. If others have arranged it can join it, you're free to join it. And then after that, you'll have to discuss with your supervisor if you wish to come out there. Okay, I'm going to stop there. I think we are done. Just to point out that there are resources that are available, very important ones on the website at profmusa.com. If you just Google it, you should find it quite easily. There's the Shewelo Community Practice CCP resources. That's useful. And then also under Johannesburg, you should find a fair amount of COVID resources as well. Let me just quickly point some of them out to you. So I'll just share with you the web page. This is the web page. So if you go to CHBAH Community Practice CCP resources, you'll see stuff there that's very useful. Clinical governance, also some useful stuff. Please have a look at it. And then COVID-19, there's also some very useful stuff here, especially in Johannesburg. A lot of the requirements or a lot of the sort of local protocols are there. Please go look at them, especially with us entering COVID. I think you need to look at some of those resources. Okay, I think that's it. I'm going to stop here. I don't know if the other people on the call, Dr. Moti, Dr. Petkova, would like to add comments. We've had some people leave. That's no problem. This is going to be recorded and available. So anybody can look at it. So I should think it'll be available. I'll try to make it available tomorrow so others can look at it from tomorrow. Maggie, Ashraf, anything?
Hello?
Yeah, go ahead.
Yes,
go ahead,
I'm
Maggie.
fine, thanks.
Ashraf. Okay, Ashraf?
Yeah, just a few comments. One is you mentioned that the rotation through ED will be at Barra.
Yeah.
It's not only at Barra, they will rotate through Bekim Langeni as well as Barra. Some at Barra and some at Bekim Langeni. That's the one correction. Okay. The second thing I needed to point out was with regard to leave. I did specify in my initial email how many days of leave you're entitled to. However, there's lots of requests for leave during to do different ACLS, BLS courses. That will be part of your annual leave and will be taken from annual leave and not from any type of special leave.
There's no study leave during this time.
There's no special or study leave with regard to that. Okay. I think that those are the two comments I needed to make.
Good. Thanks. That covered most of it. Okay, Maggie, anything you'd like to mention?
No, I'm fine. I have orientated the group this morning in Discoverers and I visited Zola Gateway because we didn't have any senior there due to post-call or different reasons. The same was in Itirlang, but I arranged in Itirlang the doctor to be there, even post-call. But from tomorrow on, we're going to have the things flowing much smoother.
Okay, so nothing else to add in terms of overall issues? So I think that should be fine. Thank you all very much. You have hopefully a good idea of what your internship is all about. Please follow the lines of communication and we will be sending out to you information and other things. Those who are joining us tomorrow, it's the same internet connection, the same link as today. So you just have to link up back to that one. Thank you all very much and enjoy the next 6 months. Take care. Bye-bye.
Thanks, Prof. Thank you.
Bye.
Bye.